ನೈಟ್ ಮಾತ್ರ ಡ್ರಿಂಕ್ಸ್ ಕೊಟ್ಟು
Starting. Respected senior doctors of the profession, IMA Junior Doctors Network team, medical students network team, postgraduate students and colleagues, a very warm and happy evening to all. On behalf of our chairman, directors and the entire SH team, we welcome you all for our monthly virtual CPC meeting. We shall now start our virtual CPC meeting with the interesting quiz questions. So the first slide we have today is an interesting ECG of a 40-year-old male who presented with complaints of lightheadedness, palpitation, shortness of breath. On examination, patient was conscious, oriented. His systemic examinations were normal. An ECG was done for the patient. What does this ECG show you? What are the findings you can think of in this ECG? And with this, what do you think will be your definitive diagnosis? What are the causes of short PR interval you can think of? What is actually short PR interval? How will you differentiate LGL from WPW syndrome? What do you think are the complications associated with this condition? And how will you treat this condition? Next, we have an interesting chest X-ray of a 32-year-old female who came with complaints of dry cough and breathlessness for 3 weeks. She was a known case of pulmonary tuberculosis who had taken ATT 1 year ago for 6 months. She did not have any history of fever. On examination, she was afebrile, BP was 120/80, respiratory system auscultation showed her breath sounds were reduced on the left side. It was stony, dull was there on percussion, mild tracheal shift was there to the right. Abdomen examination was normal. With this history and this chest X-ray, what will be your clinical diagnosis? What does her X-ray chest show? How will you evaluate this patient further? What is Light's criteria? And how will you manage this patient further? And with this, what can be your final diagnosis? Next, we have a 67-year-old female presented to us with complaints of dysphagia and vomiting for the past 3 months. On examination, she was conscious oriented. Her systemic examinations were normal. She was subjected to a barium swallow. The picture is shown here. What are the findings you can see in this her barium swallow X-ray? How will you proceed further? What do you think could be the causes for this condition? And what is POEM procedure? Next, we had a 49-year-old male who presented with high-grade fever with chills and rigor. On examination, vitals were stable. Systemic examination per abdomen, splenic tip was palpable. With hooking method, temperature was above 100 degree, and it did not touch the baseline, and spikes were there in the history once every 48 hours. With this history, how will you evaluate this patient? A smear study was done for the patient. It is shown here. What do you think are the findings in this smear? What do you think is the pattern of fever he's having? What are the complications of this condition? With this, what will be your diagnosis and how will you further manage this patient? Next, we had a 60-year-old lady who came to our OPD with complaints of fatigue, weight loss, and dysphagia for the past 6 months. She also had a left-sided neck swelling for the past 2 months. She had no other comorbidities. Her vitals were stable. The clinical picture is shown here of the neck swelling. What do you think is the finding, differential diagnosis of this finding? What is Trousier's sign? What is the clinical significance of this condition? How will you proceed further? And how will you manage this patient? Next, we had a young female who presented to the emergency department with complaints of vomiting, headache for the last 3 months. She had no neck stiffness, no fever, no seizures. Her fundus showed bilateral papilledema. Her vitals were found to be, she was alert. Vitals were normal, pulse rate was high. With this history, what will be your diagnosis? The patient was then further evaluated. And an MRI was taken for the patient. MRI picture is shown here. What do you think are the classical features you can see in this MRI picture? How will you proceed and treat this patient? And during the procedure, a biopsy was also taken for the patient. The biopsy, the HP picture is shown here. What do you think will be the diagnosis from it? Next, we have an interesting ABG, a 52-year-old woman, a known case of left leg cellulitis, a diabetic who came with complaints of vomiting, breathlessness, and tiredness since 1 day. On examination, her BP was 130/70, pulse rate was 146 per minute, respiratory rate was 40 per minute, saturation was only as 94 at room air, signs of dehydration was there, blood sugar was 359, urine acetone was positive, and ABG was done for the patient also. With this history, what will be your diagnosis? The ABG results are shown here. How will you interpret it? What are the causes of high anion gap metabolic acidosis? And what are the causes of normal anion gap metabolic acidosis you can think of? And with this, how will you manage your patient? We had another 57-year-old male, a chronic alcoholic and smoker, who came with complaints of abdominal pain, distension, nausea, and vomiting since 3 days. Patient pulse rate was 96 per minute. Per abdomen examination, it was distended, diffuse tenderness was there, shifting dullness was there on percussion also. With this clinical history, what can be your clinical diagnosis? How will you proceed? The patient was subjected to a series of investigations. An ultrasound was done. What are the findings you can think of in the ultrasound picture shown here? And with these findings, a CECT abdomen was also ordered for the patient and it was done. And the CECT picture is shown here. What do you think are the classical features you can see here? And with this, what can you think of will be the final diagnosis? What are the other differential causes you can think of for this case? And how will you manage this patient further? Next, we had a 42-year-old male, a chronic smoker, who presented with complaints of dysphonia, deviation of tongue to the right, and history of aspiration 3 days ago also. On examinations, vitals were stable. He had a swelling on the right side of his chest, which was very hard in consistency. With this, what can be your clinical diagnosis? And laryngoscopy was done for this patient. You can see the video, it is very clear. What is the nerve supply of the larynx? I can play it one more time. What are the causes of this condition? With this, what will be your final diagnosis? And how will you treat this condition? Thank you. So as our participants are all delegates are pondering over the answers for the quiz questions, we shall now start our meeting with a prayer, as everything starts with the Almighty. Physician's prayer. Dear Lord, thou great physician, I kneel before thee. Since every good and perfect gift must come from thee, I pray, give skill to my hand, clear vision to my mind, kindness and sympathy to my heart. Give me singleness of purpose, strength to lift at least a part of the burden of my suffering fellow men, and a true realization of the rare privilege that is mine. Take from my heart all guile and worldliness, that with the simple faith of a child, I may rely on thee. SAH prayer. Almighty Lord, the source of pink health, we submit our heartfelt gratitude for healing the dreadful and the chronic patients through our hands. Bless our Sundaram Arulrhaj hospitals with all the doctors and staffs. Let them shine up in their efforts to heal the sick and develop the science of medicine. We thank you, O Lord, for picking us for this health services to create the healthy longevity for healthy citizen and healthy, vibrant India. Thank you. We shall now start our virtual CME, and the first talk for this evening will be on IVF in infertility, when and why, which will be presented by Dr. Mrs. Archana ma'am, our consultant fertility specialist. Welcome, ma'am. We'd like to hand over the podium to ma'am. Over to you, ma'am. Ma'am, you need to unmute.
Good evening to all.
Yeah, you're audible.
Is my screen seen?
No. It's not sharing. Sharing option has come, na?
Yeah, it has come as share screen.
Okay. Just click on that. Is your
Yes.
PPT already open? It should be already open. Only then it will show. Minimize the screen, open the PPT, and then you make this again bigger and come back and share.
Is my screen seen?
Yeah, it's seen now. Yeah, you can go on it, ma'am.
So good evening to all. I'll now be talking about the role of IVF in infertility. So we all know that infertility is a problem which is on the increase, and in fact it is actually emerging as a global disease. And according to WHO, the overall incidence of infertility among the reproductive age group is about 10%. And IVF has evolved as a major treatment protocol for infertility, and it's been 42 years now since the birth of the first baby by IVF. And now with the introduction of ICSI, the more advanced form of IVF, we can treat even more severe forms of male infertility. And the Indian incidence is also similar to the worldwide incidence of 10%. And this is all increasing mainly due to our lifestyle pattern and diet. So going to the indications, any cause of infertility is an indication for IVF. That's what I'll say it in a nutshell. It could be female problems, male problems, or combined both male and female problems, or when they have no problems at all. Every testing is normal and there are a couple of unexplained infertility. So any indication when other treatments have failed, it is an indication for IVF. So before I go into my case presentation, I'll just brief the steps in the IVF cycle. So the steps include the initial evaluation of the couple, suppression of the natural hormonal cycle, ovarian stimulation with gonadotrophins, collection of oocytes and the sperms, in vitro fertilization of the oocytes by the sperms, and the embryo transfer. So the initial evaluation involves evaluating both the partners. It is always important that we should evaluate both the female and the male partner before we start any form of infertility treatment. The basic blood tests are done, and the hormonal profile include all these hormones, which include the FSH, LH. This is the fertility panel of hormones, the thyroid profile, prolactin, estrogen, progesterone, and AMH. AMH is an anti-Mullerian hormone and gives you the fertility potential of the lady. A baseline fertility scan, and this is a transvaginal scan. Only a transvaginal scan can give you all details regarding to fertility treatment. That is entire details about your uterus and the ovaries. And a sonosalpingography is a saline infusion into the uterus and evaluating the uterine cavity. It is very important that we evaluate the uterine cavity thoroughly before we plan an embryo transfer. And a detailed semen analysis for the male partner to look for his sperm count, the motility, and any other morphological defects in the sperm. The next step is the suppression of the natural hormonal cycle. This is to prevent the spontaneous ovulation, because if natural ovulation occurs, we will not be able to retrieve the eggs for IVF. And the drugs commonly used for this purpose are the oral contraceptive pills and GnRH agonists or antagonists. Next step is ovarian stimulation. Here the ovaries are stimulated to produce multiple mature follicles. So we need multiple mature follicles to get many number of good quality oocytes, which can be fertilized in vitro. So we need many oocytes because not all oocytes do get fertilized, and even among the fertilized oocytes, not all oocytes develop after the fertilization. That's the reason for that's the reason for stimulating the ovaries to produce multiple follicles. And generally, the stimulation is with gonadotrophins and is given for 8 to 14 days. And stimulated ovaries are followed up for the follicular growth by transvaginal ultrasound scanning. So these are the drugs which we use for the ovarian stimulation. All types of gonadotrophins can be used, the HMG, FSH, LH. LH is generally used in along with FSH and not alone, HCG. And for mild stimulation IVF, we can use clomiphene citrate. And the drugs to prevent, and we always support the stimulation with drugs to prevent premature ovulation. And for this, we use either GnRH agonists or antagonists. The next step is the collection of the oocytes. And once the ovarian stimulation is completed, for final oocyte maturation, injection HCG is given. And 34 to 36 hours after the HCG injection, the oocyte retrieval is performed. And the oocytes are retreated through a needle which is connected to a suction device. And this is performed by a transvaginal ultrasound guided aspiration. You can see here it's connected to a suction pump, and this is done under a transvaginal ultrasound guided aspiration under a short GA. It is a short procedure, usually completed within 30 minutes. In certain conditions, when the ovaries are not accessible, for example, in endometriosis, where the pelvic anatomy is totally distorted, we may have to go laparoscopically to retrieve the eggs. So if the woman is a normal responder with a good ovarian reserve, we generally expect anything between 10 to 15 oocytes. But this number is not fixed. It depends upon the woman, it depends upon her egg count. Where in a woman with a poor ovarian reserve, it can be anything as less as 4 to 5 oocytes. And in PCOS women who has many number of eggs, they generally tend to be called as hyper responders. In them, we can expect 15 to 20 or even more number of oocytes. So once these oocytes are collected, they are prepared and stripped from the surrounding cells by a process called hyasing it. And then they examine in the IVF lab for maturity and quality. The mature eggs, we call them the M2 oocytes. That is, they are in the M2 phase of the meiotic cycle. These eggs are placed in the IVF culture medium along with the sperms, and they're transferred to the incubator for fertilization. So soon after the collection of the oocytes, the semen collection is done. And the male partners usually advise a sexual abstinence of 3 to 4 days. And the collection is done 60 to 90 minutes prior to fertilization and not a long time before. Once a sample is collected, it is liquefied, processed by centrifugation, and is suspended in a culture medium, incubated for 30 to 60 minutes at 37 degrees Celsius. Following this processing, the most active sperms will be located in the surface of the medium. And it is these sperms that we are going to use for either an IVF or an ICSI procedure. If the semen does not contain active sperms, either due to an obstruction or due to lack of adequate production, we can go for a direct surgical sperm retrieval from the testis, epididymis, or the vas deferens. So these are the various surgical sperm retrieval techniques. And among these, a common method that we are using is the testicular sperm aspiration, the TSA. And if by testicular sperm aspiration, we are not able to retrieve sperms, we go for an open testicular biopsy. So once they are retrieved, of course, the fertilization is started by adding 10,000 minimum of 10,000 to 50,000 motile sperms into the culture medium along with the oocytes and incubating them for for fertilization to occur in the IVF procedure. But if the male counts are too low, it's less than 10,000 motile sperms, then we have to think of ICSI. ICSI is the intracytoplasmic sperm injection. So in this process, we are directly injecting a motile sperm into the oocyte and fertilizing it, and then incubating it for further growth of the embryo. So here the embryologist isolates the sperm, draws it into a microscopic needle, and injects it directly into the oocyte using a high-power ICSI microscope. The oocyte is held with a larger holding pipette. With a smaller pipette, a single live active sperm is selected and is injected into the cytoplasm of the oocyte, and then transferred to the incubator for the further growth of the embryo. The fertilization check is performed the next day. That is approximately 18 hours after either an IVF procedure or an ICSI procedure. Usually 65 to 75% of mature oocytes will fertilize if the lab is maintained in the good condition. And these are cultured in special incubators to support division and development. And it is in this stage of the embryo, we can plan a pre-implantation genetic diagnosis if the couple have a history of certain genetic disease, or they are a couple with recurrent pregnancy loss or repeated IVF failures. So this is a very interesting slide. You can see the development of the embryo. So the first day we perform the ICSI, and that is the day 0. The day 1 is when it is the 2-cell stage where you can see the male and the female pronuclei. Day 2 is the 4-cell stage. Day 3 is the 8-cell stage. And day 4, it becomes a ball of cells. That is, it is called the morula, in which you have 16 to 32 cells. And this is day 5 is the blastocyst. That is when this ball of cells starts clearing up to form the cavity, when it has around 200 to 300 cells. So this is a recap of our embryology. The last step in the IVF cycle is the embryo transfer. And this can be performed by using either day 3, day 4, or a day 5 embryo. One or more embryos are suspended in a drop of culture medium. It's drawn into a transfer catheter with a syringe at one end, and the tip of the catheter is generally guided through the cervix into the uterine cavity, placed in the mid position of the uterine cavity, and the embryos are transferred. And this is done under ultrasound guidance. And generally 2 or to maximum 3 numbers of embryos are transferred per cycle. So this was a short recap of the IVF cycle. Now let's go into some of the interesting cases, commonly encountered cases for whom we had performed IVF. So this first case, Mr. and Mrs. M, they were a case of primary infertility, married for 6 years. Going to the female partner's history, she was a 28-year-old housewife. She was obese, her BMI was 31. Otherwise, she had regular cycles. She had undergone a diagnostic hysterolaparoscopy 3 years back, which was normal. Her hormonal profile was all normal, and her ultrasound-wise also was normal. Her previous treatment history-wise, she had undergone 3 cycles of ovulation induction with a natural try, and 8 cycles of donor IUI, which had all failed. Going to the male partner's history, he was a 34-year-old supervisor, municipal supervisor with a BMI 42. He was morbidly obese. It was a known case of diabetes and dyslipidemia on treatment. And his semen analysis showed severe oligozoospermia. There were only occasional motile and immotile sperms seen in his semen sample. So because of his very low counts, we had performed this hormonal analysis for him. His hormones were all normal, and a scrotal Doppler and a transrectal ultrasound to look for any kind of obstruction to the sperm transport was all normal. So a diagnosis in this case was severe male factor, obesity in both partners, and previous 8 failed donor IUIs. So the couple was advised weight reduction, antioxidants and antibiotics were given. For the male partner, after consulting the andrologist, injection HCG was started weekly once, and the plan for the couple was ICSI with the husband's sperm. So the IVF cycle was started, ovarian stimulation was done, and on the day of oocyte retrieval, we got 11 mature oocytes. The semen analysis on the day of oocyte retrieval was, he had a sperm count of 1 million and a motility of 90%. ICSI was done with the husband's sperm. 9 embryos had grown, and we transferred 3 embryos. These were 3 embryos we had transferred for the couple, and the patient became positive. Her beta HCG values were good. An early pregnancy scan was performed 3 weeks later, and it was a twin gestation. It was a dichorionic diamniotic twin gestation. The antenatal period was uneventful. At 35 weeks, patient presented to us with reduced fetal movements and was taken up for emergency cesarean section. And she delivered 2 male babies weighing 2.035 kg and 1.8 kg. Both babies were kept in the warmer by the mother's side for 8 to 10 days. Both babies did well and were discharged in healthy condition on the 10th POD. So this was the first case of a severe male factor. Going into the next case, this couple, case of again primary infertility, married for 4 years. Looking at the female partner's history, she was a 29-year-old software engineer with a normal BMI. They were from Bangalore, although they were native of Tuticorin, Kovilpatti. They were at present at Bangalore. The girl, she always had irregular menstrual cycle since Menarche. She was a known case of PCOS with clinical hyperandrogenemia. She had typical acne, hirsutism, and everything you can see, the acanthosis, everything. And her hormonal profile showed her AMH was high. The normal AMH value is 4 to 6.7. Anything beyond 6.7 is high, and it is usually higher in PCO women. So that AMH value of 8 indicated that she had PCO. She had also, and ultrasound also revealed that she had bilateral severe PCOD. She had undergone a diagnostic hysterolab with the bilateral PCO drilling 5 years back. Previous treatment-wise, she had several cycles of ovulation induction done, 3 cycles of IUI, and 2 cycles of IVF, which had all failed. Going to the male history, he was 32-year-old with a normal BMI and normal sperm count. So the diagnosis for this couple was severe PCOS with previous 3 failed IUI and previous 2 failed IVF. So the couple was started with antioxidants and antibiotics, which is a routine before you go in for the IVF procedure to prepare the oocytes and the sperms for the IVF process. The female partner, in addition, because of her severe resistant PCOS, she was started on metformin and myoinositols to bring down the insulin resistance. Cycles were regularized with OCTs. And because she was a case of previous 2 failed IVF, we had performed a pre-ART hysteroscopy, which was a diagnostic hysteroscopy to evaluate the uterine cavity to look for any other problems that could have been missed, which could have led to the failed IVF, but it was normal. At that time, we had also done an endometrial TB PCR for her, which was also negative. And for the male partner, again, because of the history of previous 2 failed IVF, we had done a sperm DFI. DFI is a DNA fragmentation index. These are not routinely done for all patients who go in for the IVF for the first time, but when they do have recurrent failures, we consider these extra testings. And sperm DFI of 15 to 20 is normal, and his report was 20%, which was good to fair sperm DNA integrity. So the couple was planned for ICSI. And on the day of oocyte retrieval, she had got 7 mature oocytes. ICSI was done. 2 embryos were grown and both the embryos were transferred. And patient became positive. And on early pregnancy scan, it was a single intrauterine pregnancy. And the antenatal period was uneventful until 28 weeks. At 29 to 30 weeks, patient came with preterm labor. And she was already in established labor. We could not give tocilizers and stop the labor. And she delivered by normal vaginal delivery, a female baby weighing 1.15 kg. The baby was referred for extreme preterm care. Baby was in NICU for almost 2.5 months and was discharged in a healthy condition at a weight of 1.7 kg. So this is the mother and this is the baby. She is a long-term patient of our chairman. And so her parents keep coming for regular checkups. And so whenever her parents come and whenever she's here in her parents' place, she does visit us and she shows a baby to us every time they come. So next case, the third case, again a case of primary infertility, married for 8 years. Here the female was 36 years, obese. She attained menarche at the age of 13 years and she was having regular cycles for 2 years. 2 years later, her cycles started becoming irregular and gradually she required withdrawal with hormones to get her cycles. Presently, she had cycles only with cyclical estrogen and progesterone. So she presented with a picture of a secondary amenorrhea. She was a known case of hypothyroidism on thyroid replacement. On examination, she was of a short stature. Her height was 139 centimeters. Breast was Tanner stage 3, which she said had developed after she had started taking the cyclical estrogen and progesterones, and axillary and pubic hair was sparse. All her hormones were elevated. FSH was grossly elevated, 64.72. So normally, even at menopause, we expect a FSH value of only maximum of 25. So hers was 64, which means she had a primary ovarian failure. LH was also elevated. She was hypothyroid. Again, TSH elevated with on thyroid replacement, and AMH was extremely low, showing that her fertility potential was almost negligible. And ultrasound showed that she had a normal uterus, but ovaries were not visualized. And she had undergone a diagnostic laparoscopy, which showed normal uterus and tubes and bilateral streak ovaries. The male partner's history was that he was 37 years, a little overweight, and on semen analysis, he had a teratozoospermia. That is, he had certain abnormalities in the sperm morphology. So our diagnosis was a primary ovarian failure with a mild borderline male factor. And for the female partner, we had done a karyotyping, which came as a 46X Turner syndrome. And because we had diagnosed a Turner syndrome, we had taken an echocardiography for her, which was normal. And for the male partner, we had started on antioxidants and antibiotics. And because there was no way she could produce her own oocytes, we had planned ICSI with the husband's sperm and donor oocytes. So ICSI was done with 10 donor oocytes and 4 embryos had grown, and we had transferred 2 embryos after endometrial preparation with HRT. So this patient became positive and her beta HCG was good. She had a twin pregnancy, but the first twin was a single live pregnancy corresponding to 7 to 8 weeks, but twin 2 was an embryonic gestation. So it continued as a singleton pregnancy. Antenatal period was uneventful, and at term, in view of breech presentation, we took her up for a cesarean section, and she delivered a male baby weighing 2.5 kg, and both mother and baby did well. So this is the last case, another common problem that we do encounter. Case of secondary infertility, married for 5 years. And the woman, she was 31 years, so a little obese. She had regular cycles. Her first marriage was at the age of 21 years. And following the first marriage, she had conceived spontaneously and she had 2 children, both delivered by normal vaginal delivery. Following which she had undergone a sterilization. Sadly, subsequently, her husband had passed away. And she was remarried 3 years later, and she underwent a laparoscopic recanalization as they were planning a baby in the second pregnancy. And following the laparoscopic recanalization, they continued to try for a pregnancy. Her hormones were normal, ultrasound was normal, and she had undergone several cycles of ovulation induction and 2 cycles of IUI, which had all failed. So the male partner, he was 37 years with normal BMI and his sperm counts were also normal. So in view of secondary infertility with a tubal problem, we had planned for ICSI for them. And she had got 13 oocytes, and the counts for the male partner was normal on the day of oocyte retrieval. 9 embryos had grown and 3 were transferred, and patient became positive. It was an singleton pregnancy. Antenatal period was uneventful. At 39 weeks, patient went into spontaneous labor and delivered a female baby weighing 3.6 kgs, and both did well. So these were some of the common problems which required IVF, for which we had done it, and IVF is a definite treatment for patients with all other problems in which they are failed. So there are certain conditions which I want to stress as the last slide before I complete, when we have to stop other forms of treatment and consider moving on to IVF. The first is when the age of the female partner is more than 35 years. When the couple is married for more than 5 to 6 years and have tried various other forms of treatment, there is no point to go on prolonging that. It's time to go on to the next step of treatment. When the woman has anovulatory cycles, particularly the PCO woman, who don't ovulate with any type of tablets, injections, or gonadotropin injections, they just fail to form follicles, fail to ovulate. When they've undergone more than 6 cycles of ovulation induction. So generally, the recommendation for ovulation induction is maximum of 12 cycles. It is said that when women have, studies have shown that when women have undergone more than 12 cycles of ovulation induction, they can develop ovarian CA in future. So it is a point to think before just repeatedly stimulating the ovaries. And when they've undergone more than 3 to 4 cycles of IUI with the husband's sperm, or more than 5 to 6 cycles of IUI with a donor sperm. Generally, the IUI success rate with an IUI is about 15 to 20% per cycle. So if the success is not there in the first 3 cycles, generally for the husband's sperm, and an extra 1 or 2 cycles for the donor IUIs, generally IUI is not going to give success beyond this many cycles. PCOD drilling is another procedure which should be done with extreme caution, because there are many other methods of treating PCO patients to make them form the eggs and to form the embryos and get their babies. Because once the PCOD drilling is done, the ovarian cortex is what is being drilled, and the eggs are all present in the ovarian cortex, which may get depleted. And we do find many patients who have undergone ovarian drilling and coming to us with poor ovarian reserve. Hence, it is a procedure which should be the last resort. And if it is being done, it should be done with extreme caution. That should be kept in mind. A second surgery for endometriosis. We all know that endometriosis recur. Any number of times you do a surgery, they will recur. But if a woman has endometriotic cyst, before doing the surgery, it is important to think twice, thrice. And if you decide on operating her, it has to be done by a person with an expertise. And the first surgery should be the best surgery. And you should never think of a repeat surgery, rather go on to the further other treatments for her infertility problem. Post-sterilization, we were always doing recanalization, but nowadays with the advent of IVF, I think we can consider doing it with good results. And a younger patient with a poor ovarian reserve, this is also a problem we are seeing quite commonly nowadays, where a woman who's just 24 or 25 years, hardly married for a year, but with very low number of eggs. So these type of patients, in spite of a younger age and that she's just married for a year, may require IVF. And lastly is the severe male factor. So when the male partner has sperm counts less than 10 to 15 million, or the motility is less than 30%, or he has defects of more than 4% in his sperms, it's important to consider IVF for these couples. So to conclude, IVF is a definite ray of hope for infertile couples that needs adequate counseling, patient caring, individualized approach, and a dedicated teamwork for a successful outcome. Thank you.
Thank you, ma'am, for an excellent and informative talk. The topic is open for discussion. Doctors, you can unmute yourself and ask if you have any queries. Or if you want later also, we can take it. You can just post it in the chat box. As we have no questions as of now, we thank Dr. Archana ma'am for the excellent talk, and we shall now move on to the second talk, which will be a case discussion for today on GBS recovery not impossible, which will be presented by our postgraduate, Dr. Nikhil Govind, and will be discussed by a consultant neurologist, Dr. Kannan. Over to you, Dr. Nikhil.
Thank you, ma'am. So, a warm good evening to one and all. So today we are presenting an interesting case of from neuro side. Myself, Dr. Nikhil, internal medicine PG. So without much ado, we are moving to the case. So our patient was a 19-year-old female, a right-handed lady, a second-year college student. Of difficulty in swallowing, followed by weakness and loss of sensation over right lower limb, with transient right upper limb weakness over 1 hour. History of presenting complaints. Patient was apparently normal 3 days back, after which she developed acute onset of loose stools for initial 3 days, 3 to 4 episodes per day, watery in nature, without any abdominal pain. She suddenly had an episode of aspiration of food contents while having food and presented to the emergency with breathlessness. And during the course in the emergency room, she developed sudden onset of weakness of both upper limbs, both lower limbs, right more than left, along with the loss sensation in both lower limbs, right more than left, with transient right upper limb weakness over 1 hour. She was not able to get up from bed or move her lower limbs, both right and left, was not able to flex the hip, knee, or toes. So there is no bowel or bladder involvement, no history of any strenuous exercises or heavy meal prior to the event, no back pain, no history of any trauma, no band-like sensation, no fever, no shock-like sensations, no history of pertaining to any involvement of cranial nerves, cerebellar or autonomic system. History of appendectomy was there 3 months back under spinal anesthesia in and outside hospital. No history of similar history in the past. No history of recent vaccination, particularly influenza. No history of DM, hypertension, jaundice, TB, and blood transfusion in the past. No similar history in the family, and not on any regular medications. So, summarizing, it was 19-year-old female with a history of loose stools and person with acute asymmetric progressive weakness of both lower limbs, right more than left, and transient right upper limb weakness with sensory loss.
So, what are all the clinical possibilities, Pa?
So, from the history, we can consider all these as DDs, particularly the acute flaccid paralysis, particularly the GBS, and hypokalemia related paralysis, then hyperthyroidism related paralysis, Then ischemic lesions, particularly the anterior bilateral occlusion, inflammatory myopathies, anti-Hornstead disease, as well as compressive myopathy, we can consider. So, moving to the examination. In general examination, patient was conscious, oriented, well built, and moderately nourished. BMI was 21 kg per meter square. There was no pallor, icterus, cyanosis, clubbing, edema, or lymphadenopathy. Fundus was normal. There was no features of thyrotoxicosis. Vitals was particular temperature was subfebrile. BP was 120/80, right upper limb in supine position. Pulse rate was 91 per minute. It was regular rhythm, normal volume, no vesicular thickening, no radial or radiofemoral delay. Respiratory rate was 18 per minute, thoracoabdominal, and was regular. Moving to CNS examination, higher mental functions were normal, PNLs were normal, and there was no wasting. Tone, both lower limbs showed hypotonia. Moving to the power, upper limb was normal only, but lower limb showed on right side 0/5 and on left side 2/5. Reflexes, the plantar on right side was mute. Deep reflexes, particularly the knee and ankle, were exaggerated. And sensory system, all sensory modalities were lost in both lower limbs. Upper limb were normal, and there was no different sensory level for sensory loss. There was no cerebellar signs, no meningeal signs. Skull and spine were normal. Autonomic nervous system were normal, and other systems were within normal limits. So, summarizing the examination findings, the asymmetrical progressive bilateral lower limb weakness with transient right upper limb weakness with sensory loss, with exaggerated deep tendon reflexes in both lower limb.
So, what will you suspect and how will you investigate?
So, from the initially we have considered all these DDs. So, since the patient doesn't have any weakness, any strain exercise or history of any food intake prior to the weakness, we can rule out the hypokalemic periodic paralysis. But for the time being, we'll wait for the investigation reports, as well as the hypothyroid related weakness. We will wait for TFT reports. But in stimulations, patient will be having posterior column sensation will be spared, but this patient is having all the sensations are lost, so we can exclude the stimulations also. Inflammatory myopathies particularly involve bulk muscles, but our patient is having sensory problems, so we can exclude the inflammatory myopathies also. Particularly anti-Hornstead disease also will be a pure motor disease. Pure motor disease, so we can rule out. Compressive myelopathy, particularly patient will be having root pains, and there will be there will be a sensory level also where this patient is doesn't have features. So from this examination findings, we can conclude our diagnosis to these three: acute flaccid paralysis, particularly demyelinating disorders, as well as hypokalemic, as well as thyrotoxic related weaknesses.
Okay, continue.
Okay, sir. Sir, we are moving to the investigation, sir. So we have done a total count, sir, in order to confirm whether the patient is in any infection or not. Total count was normal and CRP was negative. We have done electrolytes, particularly in acute flaccid paralysis, severe condition, patient can have hyponatremia. Patient was having normal sodium levels, and in order to rule out hypokalemia related weakness, we have done a potassium levels which was also found to be normal. We have done a motion routine to rule out any infection in a gastroenteritis related weakness, but the patient motion routine was found to be normal. We have done a CPK to rule out myopathies, and CPK was normal limits, and TFT also normal. So the hypokalemia related periodic paralysis as well as hypothyroidism related weakness, as both of them ruled out. So we have done an echo, CT as well as MRI, which all within normal limits. So next, since all the investigation were found inconclusive, we moved to CSF analysis. CSF analysis, we were looking for any aluminocytology dissociation, but there was no feature suggestive of aluminocytology dissociation. Protein was in normal limits, and cell count was also in normal limits. So we have done a nerve conduction study of both upper limb as well as lower limb, and the FWAVE was not obtained in both upper limb and lower limb. FWAVE is particularly lost in demyelinating disorders, and there was increased distal latency with decreased conduction velocity and amplitude in bilateral cerebral nerves and right ulnar nerves, and this suggested the early demyelinating and axonal polyneuropathies.
So, what is the final diagnosis and how will you treat this patient part?
Sir, from the history and examination, since the patient is having acute flaccid weakness of the lower limbs, it is acute element syndrome, and it was asymmetrical sensory motor involvement. And since the long tracks, particularly the motor system as well as the posterior column is involved predominantly, it is a demyelinating disorder where patient was having some gastroenteritis prior to the weakness. So it is presented by the GI infection and with the respiratory compromise without any cranial involvement. Probably it is acute inflammatory demyelinating polyneuropathy, particularly the paraplegia variant or the atypical GBS. We are telling the atypical because the specific features favoring the atypicality is mentioned in the box. Usually, the typical GBS will be involving the symmetric weakness will be there. Our patient is having asymmetric weakness, and all sensitive modalities are lost in our patient. Particularly in GBS, they will be having only long tracts, particularly the posterior column. Some amount of sensitive loss will be there, but yeah, in our patient, all the modalities are lost. It is also a typical feature. Then normally in GBS, there will be depressed or normal reflexes in lower limb, but this patient is having hyperreflexia. And in CSF, we have no alveolar cytology dissociation, as well as in NCS, we are having an additional axonal component also involvement. Particularly, the typical GBS will be having demyelinating, pure demyelinating features. So from this, we are concluded that probably the paraplegia variant or atypical GBS variant of AADP. So moving to the treatment, sir.
Okay, how will you treat this patient? How will you treat the patient?
So, sir, since we are considering this an acute element syndrome, we treated the patient with IV 15 grams per day given for 3 days. Even on the day 1 after giving the IVIG itself, patient improved drastically. You can see the patient. Patient came with a power 0/5, but now she can lift against the gravity at the 2/5 is there. So on the day 1 after starting IVG, the patient showed drastic improvement. And after 3 days of starting IVIG, patient was able to walk with support. You can see in the image, in the video. Then other supporting medications we also given. So moving to the course in the hospital. So we diagnosed it as an inflammatory polyneuritis, and there was managed symptomatically. On the day 2 admission, patient had some breathing difficulty. In view of impending respiratory failure, patient was intubated electively. The NCS was suggestive of demyelinating and axonal neuropathies, and patient started on IVIG and steroids. On day 2, after starting IVIG, patient extubated, and she improved well with the immunosuppressants. So moving to discussion part, the Guillain-Barré syndrome is a rare disorder in which the body's immune system attacks your nerves. Weakness and tingling in your hands and feet are usually the first symptoms. Exact cause of Guillain-Barré syndrome is unknown, but 2/3 patients will be having infection 6 weeks prior. So the different classification of ADP are mentioned here. The classical GBS will be having a proximal mode of weakness with distal minimum sensory loss, with or without an respiratory or cranial movement. The next one is a Miller-Fisher syndrome. It's a triad of ophthalmoplegia, ataxia, and reflexia. And the Aman and Amstan is mainly axonal variant, where the distal is involved more with abs and reflexes, and it will be having poor prognosis. Next is paraplegia variant, next is focal variant, and the bibrachial variants. So what are the causes of GBS? The GBS can be presented by any respiratory or any gastrointestinal infection, particularly Candida jejuni, and viral infections like CMV or EBV or Zika virus. And also vaccination also rarely causes GBS, particularly influenza and herpes vaccines. So what are the signs and symptoms typical for GBS? So usually affects symmetrically, and symptoms usually appears over a few days, and there will be loss of reflexes, and there will be high protein in the CSF. So how to diagnose GBS? So lumbar puncture is mandatory. In this, majority of patients will be having the feature of alveolar cytology dissociation. And next one is NCS. The typical features the GBS in NCS is mainly the prolonged distal latencies. There will be demyelination, thereby conduction velocity will be reduced, so that the prolonged distal latency will be there. And there will be, if there is any demyelination at a particular point alone, there will be partial conduction block. And you can see here, this is F waves, which is normally seen because of the antidromic conduction of the nerve fibers, impulses to the cell body, and these waves will be either delayed or will be absent in patient with demyelinating disorders. In our patient, the F wave was not seen, so again, specifically, I can confirm the diagnosis as it is a demyelinating disorder. And moving to treatment, the treatment part, our patient improved analysis of upper and lower limb, no bladder or bowel involvement, no cerebral involvement, improved with IVIG and steroids. Take home message is inflammatory polyneuropathy, IVIG with steroids is mainstay of recovery. If there is any, if you delay, the patient may go for plasmapheresis. Or you, sir.
Okay, good. Can you hear me?
Hi, sir.
Okay, good. Any questions you can ask?
So as of now, we don't have any questions in the chat box.
Thank you, Nikhil. Thank you.
That
Thank
was a very interesting case. Clinical points to ponder in the above case. We also thank Nikhil for his good case presentation. With this, we shall move on to the last agenda of today, for which we request our chairman, sir, to give his concluding remarks about the cases and also discuss the answers for the quiz album. Over to you, sir.
Good evening to all of you. I'm so happy to be here in this, excellent clinical pathological conference of our institution. Two cases have been presented, one done by our senior, obstetrician and infertility specialist, Dr. Archana. She has made us to understand what is infertility, how infertility can come, how it could be managed, and what is the role of IVF and when it should be definitely the indication. She has done well and she is doing a very great job. I am sure with her continued persuasion and passion in that subject, she will achieve greater heights. I am confident of it, and best wishes to Archana. Now, the second case is so interesting. Since the time is up, I would like to, go briefly. It's a quadriparesis, which turned into be a paraparesis. When there is a lesion, paralysis of the limbs, we will have to rule out whether it is upper motor neuron lesion or lower motor neuron lesion. And when it is upper motor neuron lesion, the treatment and the cause is different and the level of lesion is different. Lower motor neuron lesion, it is different. Here it is a lower motor neuron lesion. How to differentiate it? That our postgraduate has already done that. The key problem here is this is an entity which we have been seeing for so many years. And there are certain differences also in the clinical entity. Sometimes, a lower motor neuron lesion has to have a hypotonia and plantar no response or fluxor. And sometimes this case has, compared to the left and right side, there was an exaggerated reflex. Probably little involvement of the, spinal cord also. Another important thing is bladder will not be involved. In severe cases, and emptying of the bladder can be a problem. Otherwise, a bladder is usually spared. That is how we make a differentiation between an upper motor or lower motor spinal lesion. The another important thing is we do a lumbar puncture and try to see the cells will not be there. If there is a meningitis and if it is an arachnoiditis, there will be always cells. Whereas here cells will not be there, but protein will be there. That is what we call it as inflammatory neuropathy. And actually, the treatment for our Guillain-Barre syndrome or inflammatory demyelinating panel has been totally revolutionized. When I started my practice in 1977, I think in 80, I had a young boy, a policeman's son. I still remember he is still alive. And he had a quadriparesis, lower motor. And sometimes the quadriparesis will lead on to respiratory paralysis very often. Only such incidences made me to get a ventilator, and I got expertised into an intubation and started doing it. There are many number of this respiratory paralysis due to AIDP was there. My teacher, Professor KS, used to guide me. This boy also had a respiratory paralysis. You will all wonder, this is the longest duration on a ventilator for a young boy. 92 days. I presented this case on many forums, and that time only tracheostomy tube had come. We had done a tracheostomy, and we made that boy to sit, to walk, and finally went home with a metal tracheostomy tube. After that, we removed it, and he is fine. Of course, with a lot of weakness, a lot of issues are all there. That day, only one treatment was available. that is steroids and physiotherapy, nothing more. We used to give sometimes an intrathecal steroid also, F-call. I used to give it. I was very much fond of it. After that, it shifted over to plasmapheresis. I had earlier an institutional neurologist who is now at Coimbatore. He used to do it. He'll get a small, in our ventilator machine filter, he will buy. And slowly we try to do the plasmapheresis and remove the plasma and replace it. Thereby the antibodies are removed. That way we were able to, recover the patient. Then came the IV immunoglobulin. The only problem was that those days it was about 3 to 4 lakhs. Nobody was ready to buy a drug for 3 to 4 lakhs. Then in those situations, either a steroid will continue, if possible, we'll do a plasmapheresis. Now, thank God, the costs have come and people mindset to buy a drug has also come. Now, this girl bought the drug. Even on the second day, she showed a lot of improvement. Third day, she highly improved and walked home. She's a nursing college student, our own student. She has come back now. By this Monday, she's joining the school. This is advantage of it. What is the message from here is, when there is a lower motor neuron paralysis of upper and lower limbs, always consider acute demyelinating inflammatory polyneuropathy. And then IV immunoglobulin is the drug along with steroids and other supportive measures. With that, now we are able to overcome this. And my congrats to our neurologist who has done this job, as well as our PG who has made a good presentation. I'll just rapidly go through the clinical album here. You find an ECG here. What is taking here, the PR interval is very short. You see that? PR interval is very short here. When PR interval is short here, we immediately look at the ascending limb of the QRS to look for any irregularity, what we call as a delta wave. Delta wave is there, it is a WPW syndrome, Wolff-Parkinson-White syndrome. When it is not there, it is only simply a short PR interval. We call it a Levin syndrome. And these two are always asymptomatic. Will go on well. But only problem is they have accessory pathways. Therefore, a P wave can get into it and go for a supraventricular tachycardia. It has to be subjected to an electrophysiological study, and if need be, you will have to cut the aberrant pathway. The second case is very simple. You will all know that a lady came with fever, breathlessness. You see her entire mediastinum is shifted to the right. The heart which has to be here has come over here. And the dome has also come down. Entire left lung field is opaque. So there is a lot of fluid and mediastinum is also shifted. The first and best diagnosis is the massive pleural effusion. When there is a massive pleural effusion, you will have to see whether it is a exudate or transudate. Simply by local, you just try to take some fluid out and make it. If it's an exudate with lymphocytes, and you can do an AD of the pleural fluid, that will clinch the diagnosis. If there is a transudate, you'll have to think for a renal failure or a cardiac failure. If there is a black fluid or a hemorrhagic fluid, you will have to go for still tuberculosis, or it can be a malignancy, trauma, or collagen vascular. This patient is already a case of known TB. A reactivation of the TB is not uncommon. Tuberculous massive pleural effusion goes well with aspiration, anti-tuberculous therapy, and steroid. Here is a case of dysphagia. Very interesting case of a dysphagia. Thanks to Ram Subramanian who has overcome that. You see here, dysphagia is due to some lesion or obstruction in the esophagus, which can be of multiple types. Here it is a parrot beak. You see, very smooth, very smooth. There can be a rough rattle. You call it as malignancy. Here a parrot beak is classical for a achalasia cardia, failure of the lower esophageal sphincter to relax. And when you just do a sphincterotomy, it usually goes well. This is an interventional endoscopic procedure. In olden days, when these interventions were not available, a repeated dilatation. I used to sometimes put in a colonoscope into the gastroscope and used to dilate and see old people have lived for a long time. What I'm trying to say is it is a benign disease. Ectomy always gives results. This is now it's a fever. Epidemic coming up everywhere, dengue or malaria. dengue or malaria. With chills and intermittent fever, it is malaria, continuous, it is dengue. That is what it goes. And we can simply make out a diagnosis, take a sample of blood and put it under the microscope and see that you are able to see the, plasmodium. This is a plasmodium falciparum malaria, and simply you make a diagnosis and you can always immediately start on anti-malarial therapy. Smear is the key for malaria. Here is a village lady who had some dysphagia, and she came to me when I happened to, she actually came for dysphagia. I saw the supraclavicular nodes here. This is closer to the, sternum mustard also. Here it is there, means we call it a Virchow's nodes. Here also it is a part of esophageal, distal esophageal growth was there, which proved to be malignancy. And she came, and this is a, secondary one, and she has been referred for further management. Always a supraclavicular node indicates malignancy. Very rarely tuberculosis, but always indicates malignancy. And there are multiple nodes. Axilla, groin, you'll have to think for a lymphoma. Here it's a very interesting problem. A very young girl came with very severe headache to a neurologist. He saw the fundus and there was bilateral papilloma. Always headache and papilloma, you should come something intracranial. CT was done and MR was done. There was a large mass here in the cerebellum, and it was occluding the pathway, aqueducta sylvius, and was casting, hydrocephalus. And immediately our surgeon opened up and he couldn't totally remove it because of close access to the midbrain, and a biopsy has been done. It's sold as a pilocytic astrocytoma, and she has been sent for further management of the malignant condition. Papilledema got relieved. This is a classical Kussmaul's breathing. Kussmaul's breathing is a deep inspiration and deep expiration. Commonly occurs in diabetics. In diabetes, we call it as Kussmaul's breathing. Always when there is hyperglycemia, when there is a steroid given or incomplete control of the blood sugar, you get it. And earlier days, we used to immediately start her on insulin drip and control the blood sugar and may replace some of the sodium bicarbonate. It goes well. Today, with the availability of ABG, we should always try to establish whether there is a high anion gap metabolic acidosis, which is classical for diabetic ketoacidosis or acidosis due to many other causes. Now, this is an abdominal pain, which I have repeatedly been stressing. When there is abdominal pain, piercing through the epigastrium, going to the back, always consider, pancreatitis. There can be an amylase, lipase raised, and ultrasound may show an enlarged, pancreas, head and body. Gold standard is always a CT abdomen, which shows you there is pancreatitis. Is there any infarct or any abscess, fluid collection, either in the abdomen, here there is a fluid, or in the pleural fluid also. Always gold standard is CT scan, then we try to manage and control it. This is a very interesting problem here. See, there's a chronic smoker, he was having some dysphonia. And I came and saw him, he had a mass in the left chest. And we just evaluated, there are a lot of deposits throughout. And there was lung also. When our EAT man saw that, there was a paralysis of the 12th nerve. See, this is the right vocal cord, not moving. Only the left vocal cord is coming, crossing the midline to meet the vocal cord. Then there is a 12th point on this side due to compression by malignant growth. Whenever there is hoarseness of voice or breathlessness or saliva sputum coming out repeatedly, consider there is a 12th palsy. Simple, indirect laryngoscope will tell you what is the lesion. And when the patient has got multiple masses, it's a multiple secondaries. You will have to do a biopsy, and we need to, go further. I think with this, we will thank all the participants, all the presenters and delegates for this excellent, CPC, and we will have a very nice, enjoyable and prosperous Diwali, and then meet in November. Thank you all very much. Good night. Good night.
Thank you very much, sir, for your valuable clinical discussion. We thank all our colleagues once again, and let's all meet again next month with a few more interesting clinical discussions. Till then, stay safe and healthy. Good night to one and all.